Hello everyone. Today we are going to talk about a drug called pantoprazole. Before we start, let me ask you one basic question. Do you know what makes our stomach acid acidic? Is it digestive enzyme pepsin or hydrogen ion? Yes, hydrogen ion. So hydrogen ion is what makes our stomach acid acidic. Pepsin is an enzyme which catalyzes breakdown of protein but is not acidic in itself. Stomach acid is corrosive, and if produced in excess, it can negatively affect the lining of stomach and esophagus. So, if this is occurring, we need to reduce the hydrogen ions. So, that's what pantoprazole does. It is a proton pump inhibitor. We have many proton pumps on the inner surface of our stomach, like these. These are the gastric parietal cells, and these groups are called canaliculi. So, pantoprazole inhibits the proton pumps in the canaliculi and reduces stomach acid secretions. Pantoprazole is used to treat or prevent conditions associated with excessive stomach acid secretion such as gastroesophageal reflux disease, peptic ulcer disease, Zollinger-Ellison syndrome, and in Helicobacter pylori eradication. This is available in oral and IV administration formulations.
Before getting into pharmacokinetics, let me ask you another question. Most orally administered drugs are absorbed from the small intestine, but where do you think pantoprazole is absorbed? Stomach or small intestine? The answer is small intestine. This is because there is so much mucus covering the inner surface of the stomach, which prevents pantoprazole moving into the depth of the structure to exert its effect. Therefore, pantoprazole first has to be absorbed in the small intestine into bloodstream, so it can be transported back to the stomach through systemic circulation. So as I said, pantoprazole is absorbed in the small intestine. It is a prodrug, meaning that it is inactive until metabolized. It is a small molecule, lipophilic, and mostly unionized at neutral pH. This means it can passively diffuse across membranes. Although it undergoes the first pass metabolism in the liver, its bioavailability is as high as 77%. Due to its lipophilicity, 98% binds to plasma protein in the systemic circulation. The volume of distribution is 9 liters for a person of 60 kilograms, which is rather small. Still, it diffuses into body tissues, including the stomach. Let me talk about how it works in the stomach in the pharmacodynamics section. As soon as a prodrug starts to be absorbed into the bloodstream, the liver begins to metabolize it for excretion. Pantoprazole is metabolized by hepatic enzymes into sulfate conjugates, which are hydrophilic and readily excreted from kidneys. 80% of these metabolites are excreted from the kidneys. Its plasma half-life is short, but its duration of action is much longer. We'll explain why in the coming sections. If administered intravenously, it can bypass the acidic degradation in the stomach and the first-pass metabolism in the liver, resulting in a greater area under the curve.
As I explained, pantoprazole is a prodrug. Because of its lipophilicity, it easily diffuses from systemic circulation through membranes into gastric parietal cells, where the pH is still neutral, and further into the secretory canaliculus, its site of action. The pH here is less than 2. Now this prodrug becomes ionized and trapped in here. It reacts with hydrogen ions and turns into its active metabolite. This is also how pantoprazole achieves its specificity. There are proton pumps in other parts of our body, but pantoprazole only becomes active in this highly acidic environment. And then this active metabolite forms a covalent disulfide bond with cysteine residues on proton pumps, or the hydrogen-potassium ATPase enzyme systems. This permanently inactivates them, as this covalent bond is an irreversible binding and the affinity is very strong. As pantoprazole's active metabolite forms a covalent bond with proton pumps, this results in their permanent inhibition. Therefore, it remains effective until parietal cells synthesize new ATPase pumps, which takes up to 18 hours. Dosing once daily inhibits maximal acid output by up to 85%. There are actually three pathways to activate proton pumps. There's a histamine pathway, a cholinergic pathway, and gastrin pathway. And there are other acid-reducing drugs which aim to inhibit these individual pathways. But because these proton pump inhibitors work at the very end of these acid secretion pathways, they achieve the highest potency.
As USMP scheduling an interdisciplinary team, the standard for the uniform scheduling of medicines and poisons is a legislative instrument to promote uniform control of how medicines are made available to the public. Pantoprazole is currently listed in Schedule 2, 3, and 4, as follows depending on dosage and administration method. For Schedule 2 or Schedule 3 dosage, a prescription is not required. Dispensing can be done by a pharmacist or an assistant under pharmacist supervision, or a licensed person where a pharmacy service is not available. Advice and counseling from pharmacists should be available if required. For Schedule 3 dosage, dispensing can only be done by a pharmacist or by a dispensing doctor for their own patients, where pharmacy services are unavailable. Unlike Schedule 2 doses, professional advice must be provided from a pharmacist either in verbal or written form. For Schedule 4 dosage, a prescription is necessary and can be issued by medical practitioners or nurse practitioners. Dispensing can be done by pharmacists with a legal prescription. Doctors and pharmacists can provide professional advice on Schedule 4 pantoprazole. Medical practitioners, nurse practitioners, and registered nurses can administer pantoprazole of all schedules. Enrolled nurses can administer under RN supervision. Assistants in nursing in some jurisdictions can also work in a similar manner. Schedule 4 pantoprazole administration requires verbal or written authorization from the prescriber. In summary, all health professionals involved in dealing with medication need to work in partnership to achieve quality use of medicines.
Now, before we think about counseling considerations, it is important to note the functions of stomach acid. Stomach acid is important in digesting food and also in protecting our body from pathogens. Therefore, if you take pantoprazole and suppress stomach acid secretion, it is natural there may be adverse effects related to compromised immune defense as well as malabsorption. The former includes increased risk for respiratory and GI tract infections, and the latter includes potential malabsorption of certain micronutrients. These adverse effects are more often associated with higher doses and long-term usage, so make sure you consult pharmacist or doctor depending on dosage. Next, there are certain patient groups who should not take pantoprazole. These include those with liver problems because it is metabolized in the liver. Pantoprazole may interfere with drugs that need an acidic environment for effective absorption or that compete for the same hepatic enzymes as pantoprazole or affect the activity of these enzymes. Proton pump inhibitors can also mask the symptoms of gastric malignancy and delay the diagnosis, so it is important to confirm that the patient's symptoms are not malignancy related first and continue to monitor this. Finally, how to take pantoprazole for the best effect. Pantoprazole is most effective when it is taken 30 to 60 minutes before the first meal of the day. That way, pantoprazole can pass through the stomach quickly while it is still empty and least acidic, enabling it to remain unionized for maximal absorption in the small intestine. And then it can later be activated in the acidic secretory canaliculi of parietal cells. Lastly, the literature has reiterated the importance of addressing other risk factors such as obesity and smoking, as well as providing drug treatment.
We hope our presentation has contributed to your understanding of pantoprazole. Thank you for listening.